Assalamualaikum. I am Dr. Safia Ajmal, consultant gynecologist. In this video, I will discuss about the vulvodynia. In a previous video, I have discussed vaginismus in detail, and in this video, I will discuss vulvodynia in detail. This is also an important topic. It mostly came in exam as role player plus structured discussion, and in this video, I will discuss as a simulated task. And I will discuss previous talks recalls scenario, and the scenario is Mrs. Aisha, 22-year-old, presented in OPD with complaint of dyspareunia for past 6 months. So first of all, you should read the scenario carefully, and after that, moving towards the task you have been given. And the task is take detailed history, formulate a management plan for your patient, address her concerns. What is prevalence of vulvodynia, types of vulvodynia, and causes of vulvodynia. So you should address all these questions after reading the scenario. In simulated task, after reading the scenario, you have to interact with the patient, not with the examiner. And first of all, you should introduce yourself to the patient and then take introduction of the patient by asking her name, age, education, occupation, and since how long they have been married for, and her last menstrual period. And take history in detail by asking her presenting complaints in a focused way. Like in this scenario, the presenting complaint is dyspareunia, so ask about its onset, duration, site, aggravating and relieving factors, and intensity of pain, characteristic of pain, and how much it affects quality of life. Pain is whether sharp, burning, intense pain, and whether it's localized or generalized. Ask all these questions related to dyspareunia, and after that you should rule out aggravating factors like history of any infection, gynecological examination or instrumentation, and ask about coitus, tampon insertion, and also rule out as her associated symptoms like bowel and bladder symptoms like UTI or IBS, and also ask about her sexual life problems with arousal or lack of orgasm and lubrication, and also ask about history of post-traumatic stress disorder. After that, you should ask about post-op history, like any history of traumatic birth. And in gynecological history, you should ask about dysmenorrhea, dyspareunia, pelvic inflammatory disease, and vaginal discharge. And after post-ops and gynecological history, you should also ask about her past medical history, like any comorbidities like herpes simplex or herpes zoster infection, any history of diabetes mellitus, hypertension, asthma, or any other comorbidity, and also ask about anxiety, depression, and previous history of vaginismus. And you should also ask about past surgical history, like any pelvic or vulvovaginal surgeries. Now, in family history, you should ask about any family history of skin conditions. And in personal history, you should ask about domestic or sexual abuse, and history of stress, and history of addiction. And in drug history, you should ask about any treatment taken, its effects so far. And also rule out her psychosexual history. Dyspareunia is of 3 types: mild, moderate, and severe. Mild dyspareunia present most of the time but does not prevent sexual history. In mild dyspareunia is that it present most of the time but does not prevent sexual history. In moderate dyspareunia, always present and intercourse possible at times. In severe form, dyspareunia inhibits intercourse, history of vaginismus, or any sexual abuse. So, there are three types of dyspareunia that are discussed. After taking history, move toward the examination. Examination include general physical examination and specific examination. In general physical examination, you have to do vaginal examination. On vulval inspection, look for skin condition, any vulval pathology, any abnormal redness, fissures, erosions, or any type of ulceration. And after that, do cotton swab test. For that, it is used for determining the area of redness and assess severity of pain. And sensory neurological examination should also be done for hyperesthesia. After that, do per speculum examination for assessment of any infection, erosion, and vulval conditions. And in per vaginal examination, look for any tenderness. Most important examination that is done in vulvodynia is Q-tip test. In this test, generally pressure is applied at 2, 4, 6, 8 and 10 o'clock position, including vestibule, clitoris, labia majora and perineum. After doing examination, move towards the investigation. There are two types of investigation: baseline investigation and specific investigation. Baseline investigations include blood group with Rh factor, complete blood hemoglobin, total leukocyte count and platelet count, random blood sugar, hepatitis B surface antigen and anti-HCV and HIV, and urine complete examination. Now, specific investigations. There is no diagnostic test for vulvodynia. Actually, there is no diagnostic test for vulvodynia. It is a clinically diagnosed. But to rule out infection, you have to advise infection screening, microscopic evaluation for wet smear, pH, by gram staining and culture. If ulcer present, then test for HPV or herpes zoster infection should be advised. And for vulval biopsy, if sign and symptoms of malignancy, vulval dermatosis and refractory vulvodynia, then vulval biopsy should be advised. Differential diagnosis of vulvodynia are infection, malignancy, trauma, it could be iatrogenic or hormonal deficiency. Now, management. In management, explain diagnosis to patient, ideally explain to the couple by sympathetically, and involve multidisciplinary team. And your aim of treatment should be optimize pain control for improving quality of life, enhance physical and psychologically well-being of patient, reduce triggers of irritation, advise patient regarding good hygiene, use of any irritant soap should be avoided, local anesthetic should be offered to patient and local application of gel should also be offered. Patient should be consulted regarding use of muscle relaxant before coitus. Also advise her tricyclic antidepressant, use cotton undergarments and advise her warm sheets, water bath. If a patient is refractory after all these, then for long-standing refractory provoked vulvodynia, patient should be consulted for surgery, that is vestibulectomy. And there are also different types of vaginal dilators for that. These are useful options in case of vaginal stenosis or vaginismus. And self-stimulation and devices. It also helps the woman to learn more their sexual response and becomes more familiar to her own body. Thank you. This is all about vulvodynia. And for more recalls of part 2 clinical exam, kindly like and subscribe my channel and press the bell icon and stay with